Then the question becomes, so what do we do next for her? So we're trying to get things going. We have a diagnosis. So we could radiate her, get her started on our systemic therapy, do local therapy with bronchoscopy, or depending on what her prognosis is, depending on where else she has disease, we can discuss simply palliating her symptoms without invasive interventions. And obviously the decision about what to do is a multidisciplinary decision. So it's lots of discussions between the oncologist, with the patient, with the radiation oncologist saying, what are we going to do? What are the goals? So what we're going to focus more on is this local therapy with bronchoscopy. So with malignant central airway obstruction, you can get something that starts in the airway. You can get things that spread to the airway. Doesn't matter so much, whether it started there or whether it went there. You have an obstruction, and you've got to figure out how to deal with it. So it's estimated that up to 30% of patients diagnosed with primary lung malignancies can present with central airway disease. And we certainly see a lot of it. It feels like we're seeing more of it. The progressive obstruction contributes to morbidity. So people get cough, people can't clear secretions, they start having hemoptysis, they start getting post-obstructive pneumonias. If you have tracheal or carinal obstruction, obviously you have one trachea and you have one carina, so that can be a bigger problem than if you have a bronchial obstruction. So in these situations, you get progressive shortness of breath, and these patients slowly asphyxiate. And again, so the decision of do I intervene is largely resting on, is this patient likely to live a couple weeks where they're going to get benefit from what I do? Or is this somebody whose life expectancy is pretty short and I don't really want to put them through an invasive, potentially risky procedure, and then have them have to come back frequently, if there are complications. So it can be a balancing act. And then bronchial obstruction, so you have two main stems, so a lot of people can live with one side, but some people can't. But you get cough, breathlessness, can't clear secretions, and again, recurrent infections. And when we talk about what we do from a bronchoscopic standpoint, we have to be very sure that we tell patients when they're trying to decide how aggressive they want us to be, that what we do is palliative. So what we do, we are not doing anything to cure their cancer, we're not doing anything to fix it. We're trying to do our best to help make them feel better. We're trying to bridge them to their therapy, or we're trying to make their last few months or so a little more tolerable. So again, the goals of therapeutic bronchoscopy in this setting are to palliate symptoms and try to improve their functional status. So when we look at mechanisms of malignant obstruction, we can have purely endoluminal disease. So you have tumor that is just in the airway, nothing outside the airway. You can have tumor that's extraluminal, so it's all external compression pushing the airway from the outside, or you have a combination of both. I'd say these are sometimes easier to deal with. These can be challenging sometimes, and these, I think, are kind of the most challenging to deal with. So this is an example of an endobronchial obstruction. So here, again, you see a tumor inside the airway. Outside the airway, you don't see any soft tissue. It's not extending through the wall. You still have a preserved wall of the trachea. So in this situation, what you should be able to do, or could do, is just try to remove what's inside the airway, and that should be all that you need to do. So you can snare it, you can piece it apart, you can do a rigid bronch and kind of core it out. But this isn't necessarily a situation where you'd have to leave a stent behind, because your airway should be patent once you get all of the endobronchial component out. So this is an example of a combination. So this gentleman actually had a history of renal cell carcinoma that metastasized to his thyroid. And so his thyroid then it obviously is right next to his trachea, and so that then eroded through his tracheal wall. So this is what it looks like endobronchially. And this was very challenging because renal cell can be very vascular and the thyroid can be very vascular. So this is a tough situation because you've got tumor outside the airway, you've got tumor inside the airway. And often what happens when you start debulking what's in the airway, it just keeps kind of coming in. You think you're kind of getting the tip of it, but then there's just lots of tumor that follows behind. So these are situations where you might debulk to get the airway open and then leave a stent behind to keep it open. And then this is external compression. So this is somebody actually that we just did a couple days ago that has, again, not terribly symptomatic, maybe a cough, a little shortness of breath that started a month ago. And this is her mass. This is what her trachea should look like higher up. As we get further down, she has significant compression of her distal trachea and actually of her proximal left mainstem. And so we put a scope down. You can see this bulge in the posterior wall. This is posterior wall, this is anterior wall. So she doesn't have endobronchial disease, she just has external compression. And so in this situation, there's not much that I can do inside the airway to debulk, to open things up. And so then this becomes a question of, can we balloon it? If we balloon it, will it stay open long enough for her to get some therapy? Do we do anything? She's not terribly symptomatic. Are we going to do more harm than good, by trying it and going to do something right now? Do we have time to get her to therapy? Or should we think about putting a stent in with the intention of taking it out once therapy gets started? And a lot of that decision sort of depends on how does she tolerate the procedure, how does she tolerate sedation, does her airway collapse, can we get through it, and then does it open up? And then if we do our EBUS and get a sample and we have some idea of what it is, at the bedside, that might help us decide how aggressive to be. So again, things we're thinking about: what can we do? What is technically feasible? Can the patient tolerate it? And I always sort of say this, so just because we can do something doesn't always mean we should. So we will frequently get consults like from the inpatient service saying, oh, this person has a narrow airway, you need to put a stent in. So I think there's a big difference between technically, can we do it, and thoughtfully thinking about, is this something we really should do? Is this something that will be really, helpful for the patient in the long run? And so we talked previously again about these endobronchial therapies that we can use. And now we'll kind of talk about airway stenting. So if we do some debulking, or if we are able to do debulking, then what's the option of putting an airway stent in? So I think people sometimes have an idea that putting an airway stent in is simply, you put a stent in, you open it up, and you're done, and everything's good. And I would argue that that is not always the case. So you're putting a foreign body, into an airway that doesn't really like having foreign bodies in it. So our reasoning for putting a stent in is, number one, is it going to prevent the airway from reoccluding? If we put it in, is it going to be helpful? Can we get to bridge the patient to some therapy? And then does it provide additional benefit to mechanical debulking? So if it doesn't provide much additional benefit, then it doesn't necessarily make a lot of sense to do it. And then we have to consider the long-term complications. So we'll talk about that in a second. So again, it's purely palliative. We can use it to bridge to systemic therapy or to radiation. There's a variety of stents out there. There are silicone stents that need to be put in with a rigid bronchoscopy in the OR. And then there are metal stents, or mainly covered metal stents are the ones that we use. And again, you can place via rigid or flexible scope. And kind of what you do is largely physician and institution dependent. So we can use them, again, to reestablish patency. We can also use them to seal fistulas. So if somebody has a TE fistula, oftentimes we'll kind of talk to GI first and see if they can stent the esophagus, but sometimes, not sure. I think we lost power. I thought I had more time than when it said 7.
Did it come back?
No. Here, it's back on.
Coming up?
Yeah.
Delete.
Oh. Oh, you do it. Okay.
Back up.
Okay. So we can seal TE fistulas, but again, often we'll talk to GI about doing it first. Sometimes GI will put a stent in, then it'll cause compression of the airway that then we need to sort of balance that with another stent in the airway. Rarely do we use stents for benign conditions. So for example, the patient with the subglottic stenosis, there are rarely situations where we'd want to put a stent in for tracheal stenosis or tracheal malacia. Sometimes we'll do it for a short term to see if they get benefit, to then help decide about maybe surgical resection of a very small area of stenosis or malacia. But the problem with stents in benign conditions is that stents can sort of trigger a very exuberant inflammatory response. So what can happen is you can develop granulation tissue on either ends of those stents, and you can end up with an airway obstruction related to that, which can then be a problem, trying to debulk that granulation tissue and then trying to get the stent out. They can also become impacted with secretions, so people can have challenges when they have a stent in. And then again, stents are often combined with other modalities like debulking and ballooning. So these are a variety of stents that are available. So you have covered stents, probably these are the more common, and then silicone stents. So these are more rigid stents with these little buttons that sort of go up against the airway. This is a Y stent. So this would go in the trachea and down the left main stem and the shorter right main stem. And then the covered metal stents, so again, these have to be put through a rigid scope. The covered stents are loaded and we can put them in via flexible bronchoscopy. So typically, if you have an area of stenosis and you're going to stent it, you put a wire in through your bronchoscope, you take the bronchoscope out, and then you put the loading device with the stent down over the wire using fluoroscopy to guide it into place. So migration can be a big issue. So this is the lady that we talked about. So she ended up having this at bronchoscopy. So remember, initially she had kind of just external compression on her bronchoscopy. So now she has endoluminal disease as well as extraluminal. So her tumor is now growing through her airway wall. And so she needed debulking, and then she had this stent put in her distal trachea. So now that's nice and open. You can see a left main stem and a right main stem. Now, unfortunately, complications can occur, and so she came in a little over a month later, acutely short of breath. She got intubated, and her peak airway pressures were really high, and this is what her stent looked like. So it was totally occluded with impacted mucus, and so that emergently had to be taken out. Luckily, she's actually done fairly well, and so several months later, this is what her CT scan looks like. So this is her trachea, and remember what it looked like before. Did not put a new one in. Nope, and she had been undergoing, treatment and therapy. So, and she actually, we would have put another one in had she been more symptomatic after we took it out, but she tolerated it okay. All right, so we're going to move forward. So bronchoscopy in obstructive lung diseases. So this is kind of a newer airway area for flexible bronchoscopy. So we're going to look at what role can bronchoscopy play in managing COPD or an emphysema. And then chronic asthma. So as you all know very well, so emphysema is a big problem. And we have a lot of medications that can be helpful in terms of managing symptoms. But one of the big problems that we have with emphysema is the dynamic hyperinflation, or the hyperinflation that happens. And so there are some people that are candidates for lung volume reduction surgery. So very select group of patients can get benefit from this. Not all centers do it. Some centers do it, and it's becoming sort of less and less of a thing to do. And it comes with high morbidity and mortality. So you've got a group of patients who are already ill at baseline, and you want to put them through a surgery, that you got to get them through, but then ideally they'll be better afterwards. And so this led to investigators looking into a variety of bronchoscopic ways to try to achieve lung volume reduction. So can we put something in the airway? Can we try to reroute, the volume somewhere else so that we can achieve some lung volume reduction? So a lot of different studies have been done. So people have looked at endobronchial valves. There's the spiration valve system, and then there's the Zephyr valve. So basically the valves allow air to come out with expiration, but they close so that air doesn't go back in with inspiration. There was the airway bypass procedure. So this was a procedure where basically we poked a hole in the airway wall and then put a small little stent in that airway wall, and you're trying to bypass the obstructed distal airways to let volume come out that way. Several of these studies were several years ago, but so that was not approved. And then Aris Medical did a biologic lung volume reduction. So we basically put a biologic material up into distal into the lungs to again try to achieve an inflammatory response to then cause some scarring and cause some collapse and atelectasis. And there was a steam procedure, kind of similar lines to the biologic lung volume reduction, and there was a coil procedure. So what it does is it induces lobar atelectasis, but it's dependent on the absence of collateral ventilation. So we know that people can have fissures that are incomplete. And so in some people you might block an airway, and you would expect if you block an airway that you get atelectasis. But for some people, they actually get ventilation from the lower lobes. and so you don't actually achieve that atelectasis. And so people that would be candidates for these sorts of things, you'd have to make sure that they have intact fissures and that they don't have this collateral ventilation. And so again, the idea is that air escapes during expiration but can't enter during inspiration. There can be complications related to anesthesia. People can cough out the valves. There can be bleeding. And then probably the more common complication can be the development of a pneumothorax. And again, you're thinking about this in patients who maybe don't have great lung function to start with. So this is the spiration valve. So this was actually, didn't get approved by the FDA for treatment of emphysema, but it can be used as a humanitarian use device in select cases for closure of post-op air leaks. So people that have maybe had a lobectomy and they have a persistent post-op air leak, we can put these valves in to try to let that